Sinonasal tumor pathology is not the most high yield in the world, but it's when you get one of these tumors, they can obviously be very challenging and very stress-inducing. So hopefully this will give you a little bit of information. We'll start with a case presentation just to kick things off. A young guy who had nasal obstructions, nosebleeds, and facial pressure and swelling. You can see this very large soft tissue mass in his left nasal cavity and maxillary sinus. This was his biopsy, and it was a pretty weird biopsy. In one area like this, it looks like your classic small round blue cell tumor, which we kind of know about, very nested, primitive cells with limited cytoplasm. This could be any number of things. The classic small round blue cell morphology. So we were getting ready to work it up as one of those when so it's keratin positive, that's helpful. But when we started noticing other areas in this biopsy which were a little different and a little weird, so areas like this, where it seems to be kind of a proliferation of almost benign appearing glands, very bland, but again, proliferative. So the question is part of the tumor? Is this some weird surface glands that are rolled up and faking us out? And then other areas of the biopsy kind of look like this, vaguely, kind of mildly spindled. So again, kind of making us wonder, is this part of the tumor? Is it just a reactive stroma? So a lot of different signals going on here in this particular biopsy.
So for those of you who heard more about cutaneous anatomy than you ever wanted to hear in your lives, you're going to hear more about basal cell carcinoma than you'll ever want to hear. Hopefully there will be a lot of take-home lessons for this relatively common and very important tumor. So one of the things you'll learn this morning is that this is a basal cell carcinoma. And this is as well. Perhaps not what you would expect. So I alluded to this in the lecture on anatomy, that basal cell carcinoma doesn't really resemble the basal layer of the epidermis, and it's really an adnexal carcinoma. It's a carcinoma whose cells are trying to recapitulate the follicular germ, the embryonic hair follicle. And this revelation actually is not new, and it came a lot before immunostaining, came from Walter Lever in 1948. Basal cell carcinomas are derived not from basal cells, but from primary epithelial germ cells. So he knew that there were cells in the basal layer of the epidermis that were pluripotential, that could differentiate into other things, and he thought that those cells were the origin of basal cell carcinoma. And this is one of the photomicrographs we looked at earlier with the primary follicular germ and its resemblance to basal cell carcinoma. So if we look at the cells of basal cell carcinoma in more detail, they resemble the cells of hair follicles more than of the basal layer of the epidermis. Citrulline, the amino acid, is present in the keratinized areas of basal cell carcinomas and in hairs. The keratin filament distribution, the types of keratin filaments, are much more similar between basal cell carcinoma and its benign cousin, trichoepithelioma, and the follicular germ than the basal layer of the epidermis. Cytokeratin 17 is present in follicular germs, in trichoepitheliomas, and in basal cell carcinomas, but not in the basal layer of the epidermis. And then the other clue that basal cell carcinoma is a follicular neoplasm is that it can show sebaceous differentiation and apocrine differentiation. And when we looked at the hair follicle, the sebaceous and apocrine glands bud off the hair follicle. So they have a common embryologic source or embryologic analogue. This is a paper that was published by Klaus Sellheier and Dieter Krall a couple of years ago about basal cell carcinoma and EpCAM, and I showed some pictures from it in the anatomy lecture, that there was a common expression pattern for EpCAM between embryonic hair follicles, and basal cell carcinoma. And you can see in parenthesis, trichoblastic carcinoma. So if you really want to be precise, trichoblasts are the embryologic cells that make hair follicles, and because this carcinoma most resembles that, the proper name for it is probably trichoblastic carcinoma. I would strongly advise you not to use that term when you leave SNOMAS and go back to your practices. The major reason we issue pathology reports is so as not to get phone calls. Number two is getting an accurate diagnosis. And the accurate diagnosis here might be trichoblastic carcinoma, but the impetus to avoid phone calls is number one. And unless you're feeling incredibly lonely, don't do this. You also might result in a patient being started on chemotherapy for the dread disease trichoblastic carcinoma.
Okay, we'll finish up talking about atypia and proliferative breast disease. There are a number of risk factors for breast cancer above the baseline population risk. This includes inherited breast cancer susceptibility gene mutations, such as BRCA1, BRCA2, and others. Having a positive family history of breast cancer, even without a inherited gene mutation, it puts you at increased risk. There's a number of lifestyle factors that have a modest risk associated with them, including diet, age at menarche, first birth. These typically apply to ER-positive breast cancers. The one we're going to talk about today is risk associated with the previous diagnosis of benign proliferative breast disease with atypia. This is important because clinical trials have shown the value of tamoxifen as a chemotherapeutic agent for patients placed into a high-risk group. Tamoxifen reduces the risk of non-invasive and invasive breast cancers, but this risk needs to be weighed against the treatment toxicities, and this is not a popular approach because of associated thromboembolic events and endometrial cancers. And this really emphasizes the importance of accurate risk assessment to better stratify patients who may benefit from risk-reducing modalities. So there's a number of challenges associated with benign proliferative breast disease and atypia. We've known since the studies of David Page from the 80s that there was an association between fibrocystic disease and an increasing breast cancer risk. Benign breast disease really represents a spectrum of microscopic changes that can be challenging in a limited core needle biopsy. And so attempts have been made to classify this spectrum into reproducible and prognostically relevant categories. So our role as a pathologist is we have a major responsibility for risk assessment given the significance of a diagnosis of atypical hyperplasia.